Hi everyone, today I'm going to talk about idiopathic or immune thrombocytopenic purpura, or ITP for short. So this is a condition that involves platelet disruption via the immune system. That means the immune system recognizes the platelets as foreign and starts to attack it. So I'm going to explain the pathophysiology first of all. So when the platelets are formed, they express this receptor called GP2B3A receptor, and this allows the platelets to aggregate, and then fibrin can come and bind to the receptors, and then this results in formation of a primary hemostatic plaque, especially when say you have a bleed, and this will stop and plug up the hole or the damaged site. So what happens here in ITP is that the body starts to produce antibodies against this GP2B3A receptor, and these antibodies are typically of the IgG subtype, and it's important to know that IgG subtype produced by the plasma cells. And what happens here is that once this IgG starts to coat this receptor, it basically marks it, and we use this term opsonizes. So basically it's telling the macrophages to come and eat it up. It kind of tags it to be phagocytosed in the spleen. So basically these platelets are rapidly removed by the spleen, and they're sent to the spleen and destroyed in the spleen. As a result, the platelets' half-life becomes a lot shorter, and they last a lot shorter in the bloodstream as well. Therefore, we get this the term thrombocytopenic. That means there's low amounts of platelets, and the normal amount of platelets tends to be about 150 to 400 times 10 to the power of 9 per liter. And it's important to bear this figure in mind. So when this happens, basically you get a low amount of platelets. As a result, patients often tend to bleed, especially from mucosal surfaces, and other and especially in the lower limbs. They form this thing called petechiae, which are pinprick hemorrhages that you can see, especially on the gravity-dependent areas in the lower limbs, more so than the upper limbs. So what happens here is basically the immune system recognizes the platelets as foreign and tries to get rid of it. So in terms of the symptoms, like I mentioned before, patients tend to bleed more. They also tend to form this thing called petechia. They can also form things called purpura, which are basically purple kind of lesions in the skin after when there's bleeding into the tissues, and it tends to be larger than 3 millimeters. Whereas for petechiae, it tends to be more pinprick and less than 3 millimeters. And patients, as a result of this bleeding, tends to also bruise easily as well, or what we call ecchymosis. So the unique thing about ITP is that there's no splenomegaly. That means the spleen does not become enlarged, and that's a very important distinguishing factor as compared to other platelet disorders. So it's also important to mention that ITP is actually one of the most common forms of thrombocytopenia. That means a low platelet count. And it's important to bear this in mind when you see low platelet counts. when you're doing a full blood count. And also important to rule out lab diagnostic errors. For example, when the platelets clump up and the automated machines can interpret that as low platelets. So lab errors is important to distinguish that from ITP. So there are two forms of ITP, which is idiopathic immune thrombocytopenic purpura, and it's one of the most common forms or most common causes of thrombocytopenia, which is low platelet count. Generally, we tend to define it as less than 100 times 10 to the power of 9, and in certain references, it could be less than 50 times 10 to the power of 9. And it's also important to note the normal platelet count. What happens here is basically the platelet is destroyed by the immune system. The immune system recognizes the platelet as foreign, and it produces antibodies against this receptor 2B3A, which has a role in platelet aggregation. And I'll make a separate video discussing that at another time. So what happens here is when the antibodies are produced against the receptor, it tags it, and it causes opsonization for the spleen macrophages to phagocytose these platelets and to remove it from the circulation. So what happens and what causes the thrombocytopenia is because the spleen removes excessive amounts of platelets. That's the most important underlying cause of this condition. As a result of decreased platelets, patients are more likely to bleed, in particular on mucosal surfaces, especially in their mouth. You can see potentially bleedings in their mucosal surfaces, in their mouth, nasal mucosa, GIT mucosa as well. So, and that could potentially be a medical emergency. So it's important to be aware of that. Patients also may have petechiae, which are pinprick hemorrhages, which are less than 3 millimeters. It tends to be on lower limbs, especially where the gravity is what we call a gravity dependent area. Patients may also have bruise and ecchymosis, and they also may have purpura, which is defined as more than 3 millimeters. Patients also do not present with splenomegaly. It's also important to know that. I'll just divide it down here. There's the acute form, and there's the chronic form. And the difference between the two is predominantly through time. So less than 6 months, we call it acute, and then more than 6 months, we call it chronic. So the difference in these two is basically that they are due to different underlying causes. And for acute type, it generally follows after a viral infection. It tends to be self-limiting, generally less than 3 months, and most patients would often not require treatment. And in chronic patients, it tends to there tends to be an underlying condition associated with it. So it's typically associated with infections, certain types of infections like HIV, influenza, and also certain connective tissue disorders like systemic lupus erythematosus, SLE, and also hepatitis C as well, and also certain underlying lymphoproliferative disorders. That means the lymphocytes proliferate excessively, and in particular this malignancy called CLL, or chronic lymphocytic leukemia, is also associated with ITP as well. It is also important to note that for acute patients, the peak age is about 2 to 5 years old, and generally it tends to be self-resolving, like I mentioned before. So there's also this condition called Evans syndrome, and what Evans syndrome is basically ITP plus hemolytic anemia. So you get lysis of the red blood cells. In addition to that, you also get ITP. So this is a syndrome that involves these two. So it's important to bear in mind when you see patients presenting with hemolytic anemia, and I'll cover that in a separate video. So I also want to mention that there are other conditions that are associated with chronic ITP, such as Hodgkin's lymphoma or Hodgkin's disease. In addition to that, also alloimmune, so after transfusion of platelets, can also result in this as well. And certain viruses like EBV could also cause it too. Sometimes it can be idiopathic, so there's no associated infections or malignancies with this condition. So, with this condition, it tends to be a diagnosis of exclusion. So next I'll talk about here is there are two forms of ITP, acute and chronic. And the difference is due to the time, so less than 6 months or more than 6 months. In acute, it tends to follow after a viral infection, and it tends to peak at 2 to 5 years old. Quite common in pediatric populations. For chronic ITP, is associated with certain conditions like infections, HIV, influenza, hepatitis C, and EBV, SLE as well, and underlying lymphoproliferative disorders could result in the generation of antibodies against the platelets. Other conditions like Hodgkin's disease, alloimmune, so after a transfusion of platelets, when you receive platelets from someone else, you could potentially develop antibodies against the platelets because your immune system recognizes it as foreign. It could also be idiopathic as well, which means there's no underlying association or cause found. I'd just like to mention Evans syndrome again. So Evans syndrome is basically ITP with hemolytic anemia. So the red blood cells are getting destroyed and hemolysis occurs. So the combination of the two is what we term Evans syndrome. The diagnosis. So basically, it's you want to rule out other potential causes. So for example, thrombocytopenic purpura, TTP, or HUS, which I'll talk about in a separate video. And also SLE, you would want to exclude because patients could present with both. And you want to rule that out as well. And also you will want to do labs. So patients would show prolonged bleeding time. They will tend to bleed more as well, even without trauma. And when you do certain coagulation tests such as PT or APTT, they tend to be normal. So no issues with the coagulation side of things. It's more with the platelets who are being destroyed at a faster rate. Also, you want to perform a peripheral blood smear. This would often review low platelet counts, and it would be helpful to rule out like the laboratory errors when the platelets clump together and it falsely results in a low platelet count. So you can also perform tests to identify the IgG autoantibody, and there are tests available for that as well. Patients should also be evaluated for HIV and hepatitis C, especially if it's a chronic condition. So if it's more than 6 months, it will be good to identify that, because as I mentioned before, HIV and hepatitis C are associated with chronic ITP. Also, other forms of exclusion, you will want to rule out certain drug effects. It can be a direct effect of the drug, or it could be antibody mediated. So one example could be the H2 antagonist, H2 receptor antagonist, which is used to treat gastric issues, called ranitidine. It's also associated with ITP as well. So let's discuss the treatment next. So in terms of treatment, like I mentioned before, the acute form tends to be relatively self-resolving. However, most adults would require treatment. So it's important to monitor patient closely to ensure that there's no active mucosal bleeding. So if patients present with bleeding in their oral mucosa, alarm bell should go off, because the gut epithelium, the gut mucosa could also potentially bleed as well, and that could result in a GIT hemorrhage, and is a medical emergency. So it's important to bear in mind, especially when patients have mucosal bleeding, and also to keep an eye on their platelet levels. So generally, patients would bleed a lot more if they have a platelet count of less than 10 times 10 to the power of 9 per liter, and that at this point, severe bleeding can occur. They could also be treated with corticosteroids. And basically what corticosteroids do is basically to block the splenic macrophages from actually removing these coated platelets. So corticosteroids is one therapy, and patients tend to respond within 2 to 3 days. Response in 2 to 3 days. And patient can also be given IVIG, so intravenous immunoglobulin. And basically what this does, it basically blocks the receptors of the macrophage in the spleen, and also blocks destruction, so decreases destruction of the platelets. And generally the response is in 24 to 72 hours. Initial dose would be 0.8 to 1 gram per kilogram. If patients do not respond to corticosteroids or IVIG, the last line or last resort would be to perform a splenectomy. So basically, by removing the spleen, we are decreasing the destruction of the platelets in the spleen and allowing them to survive in the circulation for a longer period of time. So splenectomy is the last resort, and there's also a lot of complications associated with it. So as you know, the spleen is part of the immune system, and it tends to help to fight off certain encapsulated bacteria, so bacteria with a capsule in it, in particular Neisseria meningitidis, Haemophilus influenzae, and also Streptococcus pneumoniae. So these three, there are vaccinations available, and it's important for patients to become vaccinated against these three. And also patients tend to be on prophylaxis with antibiotics, with penicillin against this bacteria. So just to summarize, basically what we have in terms of diagnosis is largely a diagnosis of exclusion. So when you perform a full blood count, you will notice there's thrombocytopenia. Bleeding is prolonged. However, PT and APTT is normal. When you do a peripheral blood smear or a blood film, you'll see that generally there will be lower amounts of platelets. And you can also perform a IgG autoantibody test. It's important to rule out certain associated conditions like TDP, HUS, and SLE, and also rule out certain drug effects like direct effects of drugs, like I mentioned before, ranitidine, and also antibody-mediated effects as well. It's also important to do HIV and Hep C tests, especially when patients have chronic ITP, which is more than 6 months. In terms of treatment wise, most adults would require treatment. However, for pediatrics, most of them would resolve spontaneously. So it's important to monitor closely, like I mentioned before, for mucosal bleeding. This is very important. And they tend to have severe bleeds, especially intracranial bleed, which I did not mention before, intracranial hemorrhage, especially when the counts are less than 10 times 10 to the power of 9. So corticosteroids can be given, and that is used to block the splenic macrophages from actually removing these platelets, and patients tend to respond in 2 to 3 days. IVIG can also be given, which helps to block the macrophages in the spleen from destroying the platelets, and they tend to respond in 24 to 72 hours, so about 1 to 3 days. It's given at a dose of 0.8 to 1 gram per kilogram initially. As a last resort, splenectomy could be performed. So by removing the spleen, basically you're reducing the destruction process. However, patients become more susceptible to certain infections like Neisseria, Haemophilus, and Streptococcus, and they're given prophylaxis antibiotics like penicillin. Thank you very much. I've also included new investigational treatments, in particular these 2 new drugs called L-Thrombopeg. So what happens here is we try to stimulate the production of platelets by giving a growth factor that we try to give you a drug that mimics the growth factor called L-Thrombopeg, and the other drug is called Fostamatinib, which is a tyrosine kinase inhibitor. So I've included articles on these 2 drugs, so you can have a read if you're interested. Thank you.